Welcome! I'm Don Renfrew, and for the next hour or so I'm going to be discussing breast imaging. I'm a private practice radiologist with the group Radiology Associates of the Fox Valley. We're a private practice radiology group and we cover 9 hospitals in central and upper Wisconsin. I work predominantly at Door County Memorial Hospital in Sturgeon Bay, Wisconsin. Sturgeon Bay is a small community of about 10,000 people located on Door County Peninsula between Green Bay, the geographic structure, and Lake Michigan, the geographic structure. The hospital here is a 25-bed critical access facility. It's at least 50 miles from the nearest other hospital. And the hospital serves most of the patients on the peninsula. There's about 25,000 year-round residents and about 50 to 100,000 people on a given summer day. It's a big resort area. Now, part of my job of serving Door County Memorial Hospital as a radiologist is being director of the radiology department and taking care of the breast imaging. And in addition, I do grand rounds. And in grand rounds for the clinicians, I will speak with multiple primary care providers. What I found in giving conferences for primary care providers is that they frequently need to have important information about what study to order under what clinical circumstances. I made a series of lectures on symptom-based radiology, and this is one of those lectures. And basically these lectures are designed to tell you as a primary care provider what study you need to order under what circumstances and what those studies are going to tell you and how to use those studies in helping care for your patients. Now these talks are for primary care providers. Note that primary care providers formerly consisted predominantly of family medicine physicians, but there are fewer and fewer family medicine physicians as time goes on. There are also very few general practice internal medicine physicians. Most internal medicine physicians nowadays go on to a subspecialty such as nephrology or cardiology, or they become hospitalists. Because of these trends, more primary care is being done by nurse practitioners and physician's assistants. And one of the main targets, if you will, of this talk are those groups of individuals, the nurse practitioners and physician's assistants. But basically the talk is for anybody that orders studies on patients having to do with breast imaging. Now, breast cancer is an important problem. In 2009, there were an estimated 190,000 plus cases in the United States. It's the #1 non-skin cancer in women. It's the #2 cause of death from cancer in women, second to lung cancer. Keeping current with breast care is very challenging. You need to know what tests are available and which ones to order and when to order them and how they all fit into the diagnostic armamentarium of breast disease. At the same time, you want to order the right study the first time every time. And so what I'm going to do is present you with a few key concepts in order to help you know what study to order for your patient in terms of breast imaging. Now, in my talks, I try to follow Cliff Atkinson's Beyond Bullet Points principles, and those principles include trying to focus on 3 or 4 main points in a talk, and then to have all the ancillary features of that talk and all the supportive data of that talk sort of support those 3 main features. And it's also important to let you, the listener or viewer of this talk, know right up front what those points are so that you can keep those in mind as we go through the rest of the material in this lecture. The important points of this lecture, the ones that I want you to remember 6 months from now, a year from now, are all going to be on red slides. And there are 3 key critical points that I'm going to try to convey in this talk. There are a lot of sub-points to those 3 points, but here are the 3 critical key points. The first one is that there are relatively widely accepted rules about how to screen asymptomatic women and how to image symptomatic women. So there's some rules that we need to know how to follow. Second, mammography is still the mainstay of diagnosis, whether it's in the screening scenario or in the diagnostic scenario. It's still the mainstay of diagnosis. It's supplemented by ultrasound, and MR plays a minor role. although an important role, but a minor role compared to mammography and ultrasound. Finally, for me, a key piece of the picture in taking care of breast patients is that careful follow-up and handoff of the patient is critical for optimal patient care. All right, so first point here is that there are a few widely accepted rules regarding breast imaging, and these are helpful to know when ordering imaging studies. Breast imaging studies, they can be divided into screening and diagnostic exams, and the rules differ depending on which of those kinds of studies you're talking about. What imaging studies do you choose for common clinical scenarios? Well, I'm going to cover some very basic principles, and while these principles are basic, they'll provide you rules for the vast majority of cases you encounter on a clinical day-to-day basis. Your common clinical scenarios are going to be either screening or diagnostic. The diagnostic ones fall into additional studies recommended by a radiologist based on a screening exam, or patients with breast pain or lump, or patients with breast discharge. Let's talk about screening first. Screening studies are usually chosen for a combination of factors that include low cost and high sensitivity. The screening test should pick up as much disease as possible, with the idea that subsequent studies done after the screening can sort out and add specificity regarding the diagnosis. So you want a very sensitive test, hopefully one that's not that expensive. In mammography, the screening study choice at this point in time is screening mammography, and mammography remains the king of breast imaging. It's been shown in multiple trials to reduce mortality in the screened population by about 30%. It's the best screening study we have. That being said, it does have problems as a screening test. It's relatively insensitive. You would like a more sensitive study, but it's relatively insensitive. It involves ionizing radiation. It's at least somewhat painful for most women, and it can be inconvenient. It also results in a fair number of false positives, and that causes a lot of needless worry on the part of patients, and it drives up medical costs. If we had some alternative method for early diagnosis, for example a serum test for tumor markers that was cheap and readily available, this would be a great advantage. This may happen, but it hasn't yet, so we continue to do mammography. Now, your general recommendations are that women have screening commencing at age 40. There was a recent flap in the U.S. because of U.S. Preventive Services Task Force had bandied about the idea of increasing that to 45 or 50. And frankly, between the ages of 40 and 45, or even 40 and 50, there are a lot fewer cancers that you're going to find once you get compared to a 50 to 55 or a 60 to 65 age group. So there is some reason for, in terms of thinking about changing that age limit up. But right now, I mean, it's pretty much embedded in the literature, and it's pretty widely promulgated that the cutoff point's at age 40. And it usually continues, so commencing at age 40, you get annual screening mammograms. Those usually continue as long as the life expectancy of the patient is at least 10 years. Now, there are patients who've had a mother or a sister or a grandmother or an aunt diagnosed at a young age, in other words, less than 40 years of age, with breast cancer. And typically, the way you want to screen in that situation, or one commonly used rule, is to screen at 5 years before the age of diagnosis of the cancer of the relative. So if mom had breast cancer at age 38, start screening at age 33 or so for the daughter. Now, note that the report on a screening mammogram will typically have a few parts, and I'll talk in more detail about the conclusion later. But at the very end, there's usually going to be a recommendation, and the recommendation is typically to return for annual screening mammography in a year if the study's normal, or a recommendation for some additional imaging studies if the screening study's abnormal. The additional studies are usually additional mammograms or compression mammograms, magnification views, or sometimes ultrasound. It's kind of uncommon to proceed directly from a screening mammogram to a biopsy. Usually you go through an intermediate step of obtaining additional images. So basically your screening study is going to have one of these two recommendations. Come back in a year for more pictures, come back soon for more pictures. How about screening mammography with implants? Well, as long as the implants aren't symptomatic, screening mammography can be performed on patients with implants using the same age guidelines as on the patients without the implants. We obtain both standard and implant displaced views in both MLO and CC projections. And what we're talking about here is asymptomatic patients, and you're screening for breast cancer in a breast that has an implant in it. This isn't a post-mastectomy breast where they've taken out the breast tissue. This is just a supplementary implant, if you will. So what we're looking for is cancer in that breast. Now you do a different workup if you're looking for symptoms, or if you're trying to primarily evaluate the implant. And those you can evaluate with ultrasound or MR, or sometimes with mammography. Of course, if you're suspicious that the implant's been ruptured, or is it some risk for rupture, you don't really want to put it in the clamp that's required for mammography. So you probably want to avoid mammography in those patients where you're working up a symptomatic implant or implant for rupture or leakage. How about screening mammography following lumpectomy? Well, technically, the first 4 years after a lumpectomy, you come back and you get what's called a diagnostic mammogram. In other words, a mammogram that is done and reviewed by the radiologist at the time that the mammography is done. After that, you revert back to screening status, even if you've already had breast cancer. You're at higher risk for breast cancer than the rest of the population, but the study can be done as a screening study. And those patients will then fall back into the screening pool at that point. Okay, so that's screening with mammography. Of course, there's you could talk for probably an hour pretty easily about all the studies that have been done to try to evaluate efficacy of screening mammography, the pros and cons, whether it really is necessary, whether we want to do it at age 40 versus 45 versus 50. I mean, there are some controversies out there, and I'm not going to deal with those at any length. I'm just going to tell you that basically screening mammography, the easy way to think about it, start at age 40, go to the patient is, has a life expectancy of less than 10 years, do it annually, and you'll probably reduce mortality in the screened population by a significant amount. Okay, what other methods of screening are there? Well, there is screening MR, or MR done for screening purposes. With the advent and scientific evaluation of magnetic resonance imaging, breast magnetic resonance imaging, it became evident that MR was more sensitive than mammography in the detection of breast cancer. And like I said before, you want a sensitive test for a screening study, so this looked like a good idea. The issue is that it's not perfectly sensitive. It's probably better than 90%, but it's going to miss small areas of cancer in some cases, and small areas of DCIS, and you won't see the tiny microcalcifications that you will on a screening mammogram. So the studies are complementary. MR is more sensitive than mammography, but mammography is still going to pick up some cancers that MR doesn't. But the real problems with using MR as a screening study are twofold. One of which is it's got some specificity problems. It's down in the 50 to 70% range. You get a lot of false positives because fibroadenomas and other benign lesions look a lot like cancer, and it's hard to make that diagnosis. And the problem is, with a probably benign lesion on a breast MR, do you biopsy that? Do you follow it with another MR? What do you do with that? It's tough to tell. The other issue is cost. I mean, MR is an expensive test. So, even though that's all the case, there are multiple organizations who advocate screening MR for certain patients. And these are patients that have a 20 to 25% lifetime risk of breast cancer. How do you know if your patient has this high of a risk? Well, the patient's going to be in this high of a risk if she has the breast cancer gene, or BRCA, and if she has close relatives with breast cancer. If you Google breast cancer risk calculator, you'll find several calculators online, and one of the better ones is going to be this the cancer.gov breast cancer risk tool. So just look that up if you're thinking in terms of this patient has a lot of family history of cancer. Does she need a MR annually along with her mammogram? Because you use both when you're screening in this scenario for these high-risk patients. Does your patient need that? You go to the breast risk calculator and figure that out. How about screening ultrasound? Is there a role for screening ultrasound? Well, ultrasound is not presently used as a screening study. although the modality is undergoing evaluation as an adjunct or maybe even a replacement to mammography, especially in patients with dense breasts and younger patients where you don't have to use radiation, you use the ultrasound machine. Fajardo in this review article did point out that at this time, sonographic screening for breast cancer should not be performed outside of carefully designed clinical trials. The point is that so far, whole breast sonography used to screen for breast cancer has been reported by single institutions to detect small invasive breast cancers, even those not seen on mammography, with generally good prognosis with negative lymph nodes. But the problem is we haven't really completely evaluated to date the risk of occurring additional costs and biopsies and all the false positives that can result from ultrasound. It's also very operator dependent. A critical issue in the controversy concerning sonographic screening for breast cancer is whether it will reduce mortality rates, and the true independent contribution of sonography to breast cancer screening can't be determined without additional multi-institutional, well-controlled clinical trials. So, performing good breast sonography can be challenging given the operator dependence. So you need a lot of experience to do that. And basically, it's not something you're going to see in most institutions, although there are places around the U.S. that do it. So those are screening studies. Mammography, still your mainstay, MR in certain high-risk category patients, and ultrasound, not quite ready for widespread use yet, available in some institutions or as a testing modality undergoing testing. How about diagnostic studies? Diagnostic studies can follow from one of a few different scenarios, the main one of which is going to be usually the radiologist's recommendation. So the patient comes in for a screening mammogram, has something abnormal on it, and gets set up for further additional studies. So your screening studies are done on asymptomatic patients. Diagnostic studies are done on those with either mammographic abnormalities or screening study abnormalities, or they're done on the basis of clinical findings. So let's look at an example of a screening to a diagnostic study. The left CC exam showed increasing breast density in the medial breast when you compare the 2007 and 2008 cranial caudal views. Here you see 3 arrows surrounding that area of density in the left breast that seem to be picking up more density through time. And that's a little bit worrisome. This woman has obviously very dense breasts. A spot compression view with this paddle in place, however, kind of smashed out that area and showed that it didn't really hold up as a definite lesion. It looked more or less like it did the year before. So in this case, you can see the spot compression device here. The edges of it are marked by those arrows. So in this case, we thought everything looked fine. We brought the patient back in another year. And here's a comparison of 07 and 09 studies, and you can see that that area that we saw in the 08 study that looked a little worrisome is now kind of reverted back to the appearance it had in the 07 study. So basically we were right in not proceeding with the biopsy or any further imaging after the 08 additional views. Here's another example of a screening to a diagnostic study. The initial cranial caudal exam showed some small clustered calcifications. When we did the magnified view on these calcifications, at the arrow there on the picture on the right, these calcifications showed some variable size, and although they're moderately large and kind of clumpy looking, and not really fine and amorphous and as bad as you might see in frankly malignant calcifications, they were worrisome enough to biopsy. Now here's the magnification view again on the left with the arrow, and then on the right is the specimen, and the specimen did include the abnormal calcifications. Here you have an arrow on the abnormal calcifications on slide 49, and the arrow shows that the targeted calcifications were included in the specimen. You always obtain specimen views. Well, typically if you're targeting calcifications with your stereotactic biopsies to document the fact that you got them in the specimen. So the pathologic diagnosis was involuted fibroadenoma with focal ductal hyperplasia without atypia in this case. So those are a couple of examples of where diagnostic studies have followed screening studies, and the screening studies have shown an abnormality that was further evaluated with additional imaging. Now, what about focal breast pain and lumps? Generally speaking, lumps and focal pain are worked up in a similar fashion. In patients older than 35, a diagnostic mammogram will be performed and the images will be reviewed by the radiologist at the time of the exam. That's kind of what it means to be a diagnostic study. And the radiologist will direct any additional views as he sees fit. So the standard, 2 views, craniocaudal MLO will be where things start. And then you might obtain a true lateral, a cone down, rolled views, magnification views, whatever is necessary to further evaluate that for the given radiologist at the given scenario. So those are the patients that are older than 35 and have either a focal mass or a lump. Either a lump or a focal pain. Now, if patients have generalized pain, it's harder to know what to do with those. You can do mammography, you can do ultrasound, but in general, the yield is going to be very low in patients with generalized pain. And it's probably going to be more helpful and definitive to image those patients with pain that have pain in such a location that they can point to it with a single finger that's reproducible. Okay, now what about patients younger than age 35? Ultrasound's exam is the exam of choice, and it also will be performed either by the radiologist or under direct review of the radiologist. And you'll try to look at that closely. And in either case, whichever study is done, sometimes you'll do the other complementary study at the time the patient's in the department undergoing evaluation. Now, lumps found on clinical breast exam by a primary care provider, those lumps and breast self-exam found lumps, the ones that the patient finds themselves, they're both evaluated using the same algorithm, but the lumps found at clinical breast exam are more likely to be malignant than those found at breast self-exam. But they both undergo the same imaging evaluation. Okay, so for those patients with a breast lump and focal pain that are over 35, you get your mammogram and then additional views at the time of the mammogram. This patient presented with a palpable abnormality at about the 12 o'clock position of the breast, and it could be barely seen on the initial craniocaudal mammogram, shown here on this arrow at the very edge of the film on image 56. So the marker is placed by the technologist at the location of the arrow. The lesion is seen at the white arrow there on the left side, and the blue arrow marks the marker that the technologist put. Now, a spot compression exam with the spot device shoved back into the chest wall as far as it could go shows the edge of the lesion as seen on that with that yellow arrow. Now, that's such a peripheral finding, and it's so hard to characterize that with that margin like that. That we just said, well, let's go ahead and do ultrasound and see what this shows. Now, so the image on the left here is going to be the spot compression view with the yellow arrow on the lesion. And then this resulted, we proceeded to ultrasound examination. Between the red arrows, there's a hypoechoic, relatively smoothly marginated lesion, but there probably is some posterior enhancement behind that. Now, this was excised, and the exam showed well-differentiated infiltrating mucinous duct carcinoma or colloid carcinoma. It was Nottingham grade 1 of 3. So that was an exam where there was a palpable abnormality. Mammography was felt to not completely characterize the abnormality. Ultrasound was performed, and on the basis of all those exams, imaging exams, a biopsy was done and malignancy was found. Now, what about when you have breast lumps or focal pain in a patient that's less than 35? Well, in these cases, you kind of flip things and you do the ultrasound first. Breast tissue is usually denser in younger patients, and the pretest probability of cancer is less than in older patients. So ultrasound is your study of choice. Now here's an example of a 23-year-old woman with a palpable lump. It was a solid lump. It was relatively smoothly marginated. There wasn't really any purpose to be served with doing mammography in this patient. We didn't feel so. Because it was a solid lesion and a palpable lump, it was surgically removed. and this was discovered to be a ruptured epidermal inclusion cyst in a 23-year-old. The ultrasound exam demonstrates a hypoechoic lesion, but since it wasn't really a normal prominent ridge of breast tissue or a simple cyst, it was decided to excise this. All right. What about breast discharge? So we talked about diagnostic studies where you're calling back patients on the basis of an abnormal screening imaging study. We've talked about diagnostic studies where you have a patient with a palpable lesion, either by clinical breast exam or patient self-exam. And we also talked about those patients that come in with tenderness or pain in one particular spot in the breast. Another clinical scenario that will arise is those patients with breast discharge. Now, all breast discharge is not created equal. Multi-pore, blood-negative, expressed-only discharge is usually best categorized as benign physiologic discharge. It's not typically worrisome for malignancy. You may have to do medical evaluation to figure out if somebody has a prolactinoma or some other medical cause of breast discharge, but you don't really have to do an imaging workup to figure out if there's a malignant cause of the breast discharge in multi-pore, blood-negative, expressed-only discharge. Now, on the converse side, you've got unilateral single-pore discharge, especially if it's bloody. You have to worry about what's going on there, and they'll need further evaluation. Your first step's usually going to be ultrasound, especially in those patients that are under 30, and you're looking for dilated ducts or focal masses. Sometimes you'll follow that with mammography, and if neither of the ultrasound or the mammography pans out to show you a definitive answer, then another test that you can do is called a ductogram or a galactogram. The ductogram is made by cannulating the nipple pore that shows the discharge, and what you do is you have to put on loops basically because there's 7 to 21 or so pores in each nipple that it might express discharge, and they're all tiny. And then you squeeze the breast and you identify the pore where the discharge is coming out, and then you take this small, specially designed needle, it's like 29 gauge, 27 gauge, so very small, blunt, angulated, and you drop that into the duct, and then you tape all that in place, inject a contrast material, take a couple of pictures using mammogram equipment, and hope for the best. Hope that you've got enough of the contrast going backwards in that duct to discover any lesion in that duct that's bleeding to cause the bleed. So you're looking at you're doing a retrograde contrast injection into the duct. Here's an example of a patient with bloody nipple discharge. She actually didn't undergo ultrasound, but she did undergo mammography. Couldn't really see anything all that overwhelming on the mammogram. She underwent the ductogram because she had single pore bloody discharge. And this is a blow-up picture of the ductogram on image 73. And what you're seeing here is that the arrow is on a filling defect in the contrast column in this breast duct. Now, what does that mean? That means that there's a lesion that needs to come out. And this was resected, and it was found to be a benign papilloma. Indeed, many times bloody discharge from a nipple is caused by a benign papilloma existing inside the duct system. But the issue is that it's going to continue to cause bloody discharge until it's excised. So you really do need to find them. So what does that leave? I mean, what don't you image? Well, again, diffuse pain, the yield is pretty low for evaluating patients with overall diffuse pain of the breast. I mean, if the patient's 47, never had a mammogram before, she needs a screening mammogram anyway, and you can justify obtaining a screening mammogram. And then, you can look for any cause of diffuse pain. The other thing is that if the patient has bilateral physiologic discharge, you really don't want to spend a lot of time and resources chasing that down because it's unlikely to yield any consequential or malignant diagnosis. In patients in their teens and early 20s, like that one we had before, ultrasound could be done for palpable abnormalities. But it probably doesn't help if it shows a solid lesion. Are you going to biopsy those or not, depending on what you show. It might help if it shows you a cystic lesion, however. So those are, in general, the widely accepted rules about how to screen asymptomatic women and how to image symptomatic women. So that was point number one of the talk. Now, point number two is that mammography is the mainstay of our diagnostic workup of patients with for breast lesions, both for screening and for diagnosis. It's supplemented pretty frequently with ultrasound, and ultrasound is widely available not tremendously expensive and very useful for evaluation of breast disease. MR plays basically a more minor role. I mean, there's been a lot of, if you will, promotion of the technique and a lot of press about the technique. But MR is very expensive, and it's not really used widespread for screening, as I talked before, because it's an expensive study, and unless there's a real high risk in the patient, you don't really want to pursue that expensive study year after year. However, it does have a minor role in certain circumstances, which I'll talk about in a second. Now, since mammography is the king and is the screening modality of choice and the most frequently used diagnostic modality, how do radiology departments know whether they're doing a good job? Well, mammography QA has kind of evolved through the years. It's evolved in part because of work done by the American College of Radiology, or ACR, and in part because of legislation that has been passed called the Mammography Quality Standards Act, which some people call MQSA. And basically, at this point, we've developed in BI-RADS a 5-point scale. Now, initially, one of the things that the ACR did was they developed a lexicon. And those are a whole set of terms, very specific terms as to what goes into a radiology report. As it turns out, this lexicon hasn't really been universally adopted, although the ACR does have a really nice book that shows you what all those terms mean. At the same time, they developed this lexicon, which is terms to describe this and that and the other particular lesion or appearance of the breast. They also developed what they call the Breast Imaging Reporting and Data System, or BI-RADS. Now, BI-RADS everybody's heard of and everybody uses. It was initially instituted as a QA tool, and it does work beautifully as a QA tool, but the utility is in that it forces a choice on the department, on the part of the radiologist, and reduces the kind of the salient characteristics of a mammogram to a single number. So in this table, you can see a BI-RADS 0 means that the patient's got to have something else done. Either you got to get the old films, or the patient has to come back for some more pictures. 1 and 2 are basically the same. I mean, 1 is negative, that means there's nothing on there to talk about. 2, it means that there may be some benign calcifications or something. Number 3 means that you're going to bring the patient back, typically in 6 months, sometimes a little earlier. But you think most likely that the lesion's benign. 4, you're going to send the patient off for a biopsy, or biopsy the patient yourself. And then 5, you're almost certain the patient has malignancy. So that 6-point scale, including the 0 as one of the points, is just really important. These people, Langlet in particular, has done a lot of work on structured reporting, very interesting papers that he's written. And in one of the papers in American College of Radiology, he thought, or he stated that, quote, "One of the greatest benefits of the entire BI-RADS initiative arises in the mandated forced choice between clinically diagnostic categories." In other words, the lexicon really did not end up being nearly as important as the BI-RADS codes. So one of the things that the BI-RADS codes allows you to do is to make sense out of large amounts of data. Now, this slide is hard to see, and I'm going to blow it up here. And basically what this shows you is some statistics, some measurements that you can generate as a radiologist, or as somebody who runs a radiology or the mammography section of the radiology department. What you're looking at is information that can be discovered from using the BI-RADS categories and some of the other information that's routinely obtained during mammography and on an ongoing QA basis. And what the BI-RADS categories facilitate is analysis of a large amount of data in a relatively easy fashion. Now, the U.S. Departments of Health and Human Services have created benchmarks or metrics for community radiologists, which can be calculated once you know these categories and gather a little data. Of the metrics, I think, at least from my perspective, the most useful are probably going to be the recall rate, the biopsy rate. In other words, if you have 100 women that come in for screening mammograms, how many of those do you bring back for additional views? If you bring back 10 out of the 100, that's a 10% recall rate. If you bring back 1 out of the 100, that's a 1% recall rate. So the recall rate is how many patients you bring back for additional studies. The biopsy rate, how many of those 100 do you end up biopsying? Do you end up biopsying one of them? That's a 1% biopsy rate, 5 of them, 5% biopsy rate, etc. The biopsy yield refers to the number of cancers you get for how many biopsies you do. If you do 100 biopsies and you end up with 50% of them being cancer, then your biopsy yield is 50%. And then cancer detection rate, how much cancer did you find? Out of all 100, did you get 1 cancer? Did you get 3 cancers? Whatever. And there are benchmarks in that. And the cancer detection rate for screening studies, interestingly, is less than 1%. It's only about 0.2 to 0.5%. So 2 to 5 out of 1,000 patients that are screened will actually have cancer. Now, this data, which I'm going to offer up, is going to be from my own hospital, my own institution, for 5,500 consecutive screening analog mammograms done over a 2-year period. The sample data is from a small hospital when we were using analog mammography. Measurements are below the benchmark for the recall rate, that's where you want to be. It was above the benchmark for the biopsy yield, that's where you want to be. It's within the benchmark for cancer detection rate, that's where you want to be. Somewhat more patients went to biopsy than recommended by the benchmark, but there's still good biopsy yield, so that's probably okay. So analog mammography, benchmarks, calculation for quality assurance, all that should be clear. Let's add another variable, and that's digital mammography. What about digital mammography? Here's an image of the same woman, same breast, medial angle black view, with analog on the left and digital mammography. Now, digital mammography, of course, uses different technology than analog mammography. It provides greater detail, especially in the superficial tissues and in dense breasts. The image data is collected and stored and displayed electronically rather than on film. Digital mammography shows greater sensitivity. Remember, that was one of the problems of analog mammography in general. Digital mammography shows greater sensitivity for detection of breast cancer, especially in women with dense breasts. And you'll see women with dense breasts, usually under the age of 50, or those who are perimenopausal or premenopausal. Now, this article by Pisano and others concluded, quote, the overall diagnostic accuracy of digital and film mammography as a means of screening for breast cancer is similar, but digital mammography is more accurate in women under the age of 50 and in women with radiographically dense breasts and premenopausal or perimenopausal women. Now, why might that be? Well, look at this digital mammogram as another example on slide 96, and what you'll see is that this is the same woman, same breast, analog versus digital, and you're going to see much better penetration. How much more detail do you see of the breast tissue? How much better do you see into the subcutaneous tissues? How much further back you see? And you can just see a lot more on digital mammograms. Now, this paper, which was published in Radiology in 2009, talked about breast cancer screening. And these authors demonstrated a reduction in the callback rate. Now remember, digital mammography is better because it's more sensitive, but these people also found a reduction in the callback rate. So in other words, fewer people were getting called back for additional views. They found 2.4% versus 3.6%. Now note that this paper is in Spain. People say, well, in the United States, you got to have a higher recall rate than that because of litigation issues. Yeah, that might be true enough. But basically, the this versus that remains the same. You're still comparing analog and digital, whether it's Spain or the US. Your recall rate is probably going to drop, or at least stay level, without any decrease in the rate of malignancy detection. And that's important because callbacks result in greater expense, and some women find it traumatizing to have to go through additional views, not so much because of the pressure compression, as the fact that you're dealing with uncertainty. I mean, your mammogram wasn't normal. Now you have to deal with the fact that you might have cancer. And even though you're brought back and additional views show that you don't have cancer as far as anybody can tell, there's still that thought. Your mammogram wasn't normal. So the reduction of callback rate is probably pretty important. How'd this all work out for us? Well, here's our comparison of analog versus digital, and we've had digital for several years now, so we've got quite a few cases of digital mammography. Our recall rate did go down from 6% to 4%. Now, one thing to point out is that this is a little bit in the weeds on the statistical technique, but there's a difference between the incidence and prevalence callback rates, because the first time somebody comes in for mammography, you don't have any old ones to compare to, and you're much more likely to call the patient back for some additional views. So that incidence rate is higher, and it's going to skew your numbers higher than the number where you've already got multiple comparison films in the past. And then that Salas article that was in Radiology that I cited before, they individually looked at prevalence versus incidence. This is pooled data, so we didn't get, we're not down at their very low rate of recall, but the rate nonetheless is pretty good here. I mean, we're down in the 5% range, and some people actually maintain that your rate should be closer to 10%, otherwise you're missing cancer. And that's a fair argument if you don't have the rest of this data, which shows that we aren't missing cancer. Our biopsy rate actually went down with the advent of the digital, which is good because, as you remember, our benchmark was supposed to be 1%. We're a little higher than our benchmark in the analog situation. Our biopsy yield went up. We're biopsying fewer patients but finding more cancer, a good thing. Our cancer detection rate, which again, the goal there is somewhere between 2 and 5 cases per 1,000. We're doing fine on that. I mean, it didn't really change. That's 3/10 or 3/100ths rather, or 1% change in those two numbers. So it's not a big change. It's not statistically significant, and we're monitoring that on an ongoing basis. And it really does stay in a very narrow band of right around that over the long haul. So that's digital mammography. You can calculate those numbers for analog or digital, either one. So that's so mammography in a nutshell. One thing that you might think about doing is, if you, as a primary care provider, have multiple different locations that you can send your patient to that do mammography, you can ask simple things like, what's the volume there? Do you have a fellowship-trained radiologist doing the mammography readings? Or you might ask something a little more subtle and ask, what's your callback rate, what's your biopsy yield, what's your cancer detection rate on your screening studies? Because those should meet certain benchmarks, as I've just presented for you here. And if you have 3 or 4 different options for sending your patients to have their mammography done, and one of them has much better values in those numbers than the other ones, then the choice should be fairly clear to you there. Okay. So ultrasound is used every day, pretty much every day, for problem solving in mammography. MR is used less frequently, and it's usually used for kind of a problem solving issues. So what's ultrasound tell you when you do ultrasound of the breast? Basically, the way I think of it, maybe a little bit simplistically, you kind of get broken down into 4 broad categories. Ultrasound, you're going to do ultrasound on patients with palpable lesions, focal tender spots, and lesions seen on mammography, and sometimes on MR. And basically, once you do the mammogram or the ultrasound study, I think of it as breaking, the results as being in one of 4 categories. 2 of these don't really require any further evaluation after the ultrasound study. So what are those 4 categories? Well, if you have a normal ridge of breast tissue or a cyst that explain what you're feeling or the pain, then you're pretty much done. The combined negative predictive value of a mammogram combined with an ultrasound is greater than 98%. So usually I'll tell these women that they've got a normal but prominent ridge of breast tissue or a cyst, and that they really, unless the abnormality becomes more prominent or in some manner increasingly symptomatic through time, you don't really need any more imaging, and you don't really need a biopsy. Here's a patient with a palpable ridge of tissue here with some arrows on slide 109, and that was just a palpable ridge of breast tissue. Here is an anechoic lesion, actually 2 of them close together. Here the arrows are around the larger of these 2, and that represents a simple cyst. Now, what about solid lesions? If you have a solid lesion, usually you're going to end up biopsying that, although there are characteristics that kind of help you lean toward a benign or malignant lesion. Now here you have characteristics that are typical for a fibroadenoma. On slide 113, you've got smooth borders, lack of posterior shadowing, an oblong shape parallel to the chest wall. Here the arrows mark the lesion on the ultrasound. And that's very typical for a fibroadenoma. Sometimes women will prefer not to have a biopsy done. In that case, you're kind of obligated to follow this, probably at 6-month intervals with ultrasound to confirm that it doesn't change in size or shape or characteristics. If it does change, then you biopsy. If it doesn't change, leave it alone. Now, on the other hand, there's lesions like this one, which are very echogenic and have an irregular margin where the white arrows are, and where the blue arrows are, they actually show shadow casting where the ultrasound beam can't penetrate very well past the lesion. And this lesion showed a pretty nasty appearance with ill-defined margins in these posterior shadowing. Those lesions are pretty much always need to come out because they're pretty suspicious for malignancy. So again, ultrasound, 4 different categories, kind of typically benign, ridge of breast tissue, cyst, fibroadenoma, maybe leave it alone, maybe biopsy it, malignant looking lesion, biopsy. Now, again, how do you get into ultrasound in the first place? You know, either you feel something in a young woman, less than age 35, you see something in a somewhat older woman on a screening mammogram. Here's a 47-year-old screening mammogram, 47-year-old woman that had a screening mammogram. Picture on the left, the arrow is at the location of a small circumscribed mass that wasn't on her prior mammogram, which I don't show. The arrow on the image on the right shows a benign breast cyst accounting for that lesion. So in this case, you're done with the study. Here is a 48-year-old woman that had an abnormal screening mammogram, different woman. This lesion, she didn't have any old mammograms, and so we just had this lesion to work with. We took her to ultrasound. Those characteristics, again, oblong, parallel to the chest wall / skin surface, iso to hypoechoic, no shadow casting, well-defined margin, sure looks like a fibroadenoma. And, you know, she was just not interested in leaving that thing in the breast, knowing that she had a lesion. It was excised and she had a fibroadenoma. Here's a 41-year-old woman with an abnormal screening mammogram. The arrow on the picture on the left on A is on a, frankly, a spiculated, ugly-looking mass. The ultrasound on the right was performed to kind of localize the mass to see if it was a candidate for ultrasound-directed biopsy, for example, since it wasn't palpable and you can see the lesion. It's ugly, it's got poorly defined margins, hard to really identify exactly where the lesion ends. It's got posterior shadowing, so it's a bad lesion. That lesion ended up being infiltrating ductal carcinoma. Now, MR is abnormal when there's a mass or enhancing breast tissue. Unlike ultrasound, like ultrasound, you know, people can easily talk about MR of the breast for an hour, just like they can talk about ultrasound of the breast for an hour. But I'm trying to go through some very straightforward rules for you to follow and kind of give you an overview of MR. Now, MR can be used for screening those high-risk patients, like I talked about before. In addition, it can be used to evaluate an equivocal lesion when you have a mammogram done. Finally, surgeons can ask for an MR to evaluate occult to palpation and mammography and ultrasound, occult lesions in the same breast as the time they discovered the cancer, or in the contralateral breast in a patient with known breast cancer. So those are sort of some of the scenarios where you use MR. Here is our same lady, our 41-year-old woman with an abnormal screening mammogram, an abnormal ultrasound, which is frankly malignant looking, infiltrating ductal cancer found at surgery. And because of her young age and other considerations, an MR was performed to search for additional cancer. What the MR showed on this image was the biopsy site with the single arrow here, and it also showed abnormal enhancement of breast tissue leading back to the nipple where the double arrow is. Now that tissue that went back toward the nipple was biopsy using imaging-directed technique, and it demonstrated multifocal high-grade DCIS that was beyond the margins of the initial surgery. So that was an important finding. So to review, mammography used daily, it's the workhorse of breast evaluations. Our quality measures, the quality measures you look at, there are benchmarks out there for them. You compare how you're doing with the benchmarks, you try to get in line with those benchmarks. Mammography is used all the time. Digital mammography is probably better than analog mammography from a couple of different standpoints. It's more sensitive and it reduces callback rate. Ultrasound is frequently used. It's pretty straightforward. Normal breast tissue and cysts are accepted as causes of palpable abnormalities. They don't require biopsy or aspiration in most cases. Solid lesions, whether they look benign or not, typically will undergo biopsy, and your MR is kind of used for troubleshooting. Okay, so that leads me to my last point, which is careful follow-up and handoff of the patient is critical for optimal patient care. Now, the whole point is to make sure that patients don't fall through the cracks. From the prior discussion about mammography QA, it's clear mammography is not a perfect test. Neither is ultrasound, neither is MR. As tragic as the shortcomings of these studies and the interpreters are, these shortcomings are understood. They're measurable in a statistical sense, and in some sense, kind of acceptable. It's inevitable that mammography is going to miss some cancer, MR is going to miss some cancer. Readers of those studies are going to fail on occasion. And the fact that they've failed in some manner doesn't really mean that we've failed as healthcare practitioners. It's just imperfections that are very hard to iron out in the nth degree. There's another completely different issue that I'm trying to get at here, and that is we've got a patient that we've diagnosed as a suspicious lesion of the breast on one of our imaging studies, and the patient doesn't get treated appropriately because of a failure in follow-up. These mistakes, I think, are really tragic, and we need to do what we can to avoid this problem. It may be an advantage, actually, to work in a smaller environment in this situation, because in cities where there are multiple imaging centers, multiple hospitals, multiple breast surgeons, and patients can go from place to place to place, I think it's easier to kind of fall through the cracks in those situations. Now, I'm just going to kind of explain very briefly sort of how it works for my small hospital and our surgical community, and you're going to have to kind of find out wherever you practice how things are done and make sure things are done correctly. So in our system, we got 90% of the people following pretty much the same simple path. They have an abnormal screening study. They get recalled into the radiology department for further evaluation, and if they get, if it's felt that they have a lesion that requires biopsy, in our hospital, all of those people have a surgical consultation. Now, in other hospitals and other practices, the radiologists go ahead and do the biopsy themselves. And that does vary a great deal. So wherever you are, you have to figure out which direction the patients usually go, and then figure out that make sure that they get there. All right. So once they go to the surgeon, a lot of times they'll come back in my community to the hospital for a lot of their care, including more diagnostic imaging or a biopsy or breast surgery done in the hospital by the surgeon. If they have diagnosis of cancer made after the breast surgery, they'll get the radiation therapy and chemotherapy and so forth there too. So basically in our system, you get this kind of circulating path between the hospital and the surgeons. And that works well. I mean, the patients are handed off pretty seamlessly. The hospital and the surgeons in town operate synergistically. What is it they do when they undertake surgical management? Well, they can do biopsy based on either palpable abnormality, ultrasound guidance, stereotactic guidance. At other institutions, biopsy, again, can be performed by the radiologist, or even, sometimes pathologists will do palpable lesions and fine needle aspirations. At any rate, you have to kind of understand your own pattern and system. Breast surgery, lumpectomy, mastectomy can be performed after that or before that. Radiation and chemotherapy can be done. And again, the pathways there get really complex in a hurry. And, you really have to keep in mind that oncologists will differ in their recommendations, and people will enter clinical trials will have them in different pathways. Once they get to the point where they have breast cancer, it does become complex as to what they have. It's kind of difficult to master all those pathways. But basically, you just have to kind of try to keep up with them. Follow-up imaging will be performed in a lot of patients after they've had their lumpectomy, and there's kind of a regular schedule for those. And as a primary care provider, you have to sort of understand that at some level, where your patient fits in the big scheme of things. So the bottom line of all that is that regardless of what the path is in your community or for your patient, you need to understand what that path is and how the patients going through it. In the event of a bad outcome, all parties are going to be held liable, especially if it's a handoff or communication issue. So there are various mechanisms that you can use to achieve ideal handoff and seamless communication. Examples include keeping a list of all the patients that you know are going to biopsy, and then looking at that list periodically, making sure that the biopsies were done, what the biopsy results were, and also automating any pathology results on your patients so that you get those results back, even if the surgeon or the radiologist did the biopsy. So you also should make sure that the patients know who to call or calls you in the event that they have a biopsy. And I would never assume that a patient would call if she doesn't get a call herself, because you need that additional layer of security. Some patients will not call if they don't hear anything, thinking no news is good news. I know it doesn't make sense, but especially if you've had a breast biopsy. But I would very much encourage you to have your patients give you a call, or to routinely call them when they've had a biopsy as part of your job as a primary care provider. So that's the handoff part of it. Okay, so what I did was review 3 key concepts regarding diagnostic imaging of the breast. And again, 6 months from now, if you remember anything from this talk, remember there are certain widely accepted rules about how to screen asymptomatic women and how to image symptomatic women, and I went over them here. Mammography is your mainstay of diagnosis. There's a QA program in place. You have some very nice statistics and benchmarks you can look at in evaluating mammography practices. Ultrasound is performed daily, basically, on breast imaging patients, and it's a great tool to sort of solve problems that arise because of issues on screening or because the patients have palpable abnormalities. MR plays a more minor supportive role. And finally, careful follow-up and handoff to the patient are optimal, or are critical for optimal patient care. Thank you very much, and I hope you enjoyed this lecture.